Onc Live Insights is a video editorial program produced by Onc Live.
Virtually every patient with mantle cell lymphoma will experience a recurrence at some point, and so it's important to have a variety of treatment options for recurrent mantle cell lymphoma. Probably the most attractive option right now would be ibrutinib therapy. This is the oral BTK inhibitor. Response rates north of 70% for recurrent mantle cell lymphoma, good tolerability, reasonably good durability to ibrutinib therapy in mantle cell lymphoma. So that's typically my regimen of choice for recurrent mantle cell lymphoma. Unfortunately, most patients will eventually progress through ibrutinib therapy. Then I will usually consider the combination of lenalidomide and rituximab. Lenalidomide as a single agent has a response rate of about 30% in recurrent mantle cell lymphoma. When you give it with rituximab, the response rates look to be closer to 60%. So I find this a very good combination for recurrent mantle cell lymphoma. And then my third option would be bortezomib therapy. Bortezomib has been FDA approved for many years in mantle cell lymphoma, has a response rate of about 33%, so it has good activity. Peripheral neuropathy is the biggest toxicity with that, but I think that's a good third line option for recurrent mantle cell lymphoma.
One of the things that we have learned in our treatment of patients with mantle cell lymphoma from the use of ibrutinib and other agents is that it seems like the mantle cell lymphoma, when it evolves from a low-grade or rather a typical mantle cell lymphoma to a blastoid variant of mantle cell lymphoma, really becomes very difficult to control, but really requires different therapies. In patients who have mantle cell lymphoma that's not of the blastoid variant, they seem to respond very nicely to ibrutinib, idelalisib, Revlimid or lenalidomide, bortezomib, but these agents, their efficacy is limited by their development of resistance and the development of transformation. So in the mantle cell population, we have seen resistance to ibrutinib developing similar to that in patients with CLL, where we see a mutation in the cysteine at 481 to a serine that really prevents the ibrutinib from binding to Bruton's tyrosine kinase. In those patients, the ibrutinib really gets converted from an irreversible inhibitor to a reversible inhibitor and really has a lot less efficacy. When you look at the data in ibrutinib, which really is my first choice for patients with mantle cell lymphoma who are relapsed, what we see is that there's actually a tail of about 30% of patients who enjoy long-term responses. And looking at the rest of the patients, we see what often can be seen as a rather short duration of response, typically in the order of about 9 months. I believe, or I hope, that by moving ibrutinib to earlier in the treatment of mantle cell patients, before we start exposing them to chemotherapy, before we might be enhancing the likelihood of developing blastoid mantle cell by the DNA damaging agents of chemotherapy, we might be able to increase the duration of that response to ibrutinib.
Ibrutinib is dosed 560 milligrams daily for patients with mantle cell lymphoma, so the dose is different than the dose that's recommended for CLL. It's daily therapy, and it's recommended to be given until disease progression or intolerance. So this is a therapy that we typically don't stop like we do with other mantle cell lymphoma therapies. If we start a patient on ibrutinib and they're tolerating it okay and they're experiencing a good response, we will just keep the therapy going until it's no longer effective. The toxicities with ibrutinib and mantle cell lymphoma are similar to the toxicities seen in CLL, generally well tolerated, a little bit of diarrhea. Some patients have muscle aches, arthralgias, a little bit of fatigue. There's a small but real risk for bleeding, and so patients need to be aware of that. And then there's a small but real risk for the development of atrial fibrillation that can occur while on therapy. So an ongoing research question would be, could you treat a patient with ibrutinib, achieve a deep remission, and then allow the patient to take a break from therapy versus the current strategy, which is to put them on the drug and then just leave them on therapy? We really don't know the answer to that question, and that is the subject of ongoing research to see if these discontinuation strategies can be applied to our patients, but we really don't know yet. Responses to ibrutinib in mantle cell lymphoma are typically quite rapid. When we have patients with symptomatic recurrent disease, we normally observe the patient experiencing relief and benefit within days of starting therapy, so the drug works fast. But it can take quite a while to achieve your maximum remission, and so the patient might be on therapy for many, many, many months before they've really reached the depth or achieved their maximal remission. Typically with chemotherapy, it happens pretty fast. You achieve your deep remission quickly. It can take longer to achieve a deep remission with ibrutinib therapy.